Good afternoon, Health and Hospital Queens. Welcome back to another Town Hall Meet. I know that you have a number of competing priorities, and so on behalf of the executive team, I want to thank you for taking the time to participate today. Of course, all our internal presenters are special, but today we have changed our usual format to bring you a special external presenter of sorts, Dr. Andrew Wallach, who will then be followed by Mr. Neil Moore, our CEO. By way of introduction, Dr. Wallach serves as the Ambulatory Care Chief Medical Officer. In this role, he is responsible for leading the overall clinical vision of ambulatory care throughout the enterprise in order to provide high-quality medical care for patients, as well as to align staff to meet the challenging environment in today's healthcare, such as the shift to population health management, value-based purchasing, and risk pool management. He is a co-chair of the enterprise-wide Ambulatory Care Leadership Council and the Ambulatory Care Gaps Committee, which is responsible for improving the quality of care at New York City Health and Hospitals, as well as serving as the co-chair of the system's Pharmaceutical and Therapeutic Committee. During the COVID-19 pandemic, he was the clinical lead for our system's response with regards to testing, vaccines, and outpatient therapeutics. He later helped lead our Mpox response and has since been named to the U.S. Health and Human Services Region 2 Executive Steering Committee, which is part of our National Special Pathogens Program. A clinical educator, he is currently a professor of medicine in the Department of Medicine, Division of General Internal Medicine and Clinical Innovation at the New York University's Grossman School of Medicine. He also serves as their Associate Director for Clinical Innovations and Clinical Affairs. Most importantly, Dr. Wallach is an internist by training and has maintained a clinical presence, a clinical practice at Bellevue for over 25 years. Today, Dr. Wallach will be speaking about the 20-minute New Patient Visit Slots Initiative. Dr. Wallach?
Great. Thank you so much, Ms. Dasher, for that very warm introduction. And before we dive in, I want to introduce my colleague, Dr. Hannah Jackson, who is joining me today. Dr. Jackson is also an internist by training and is the Chief of Staff in the Office of Ambulatory Care and Population Health here at Central Office, where she manages several portfolios, including realignment, access, and digital health. So thank you, Hannah, for joining us today. I'm going to go ahead and share my screen, if that's okay. And I'm just going to put us into slideshow, and hopefully we should be in good shape. So really the reason why, and I want to thank the Queens Hospital Administrative Leadership for inviting myself and Hannah to join you today, because really we have a burning platform, and that is meeting unmet demand in primary care, not just at Queens, but across our system. And on this slide here, you can see what that burning platform really is. Starting in fiscal year 21 to date this year, and we know that the fiscal year has not closed out completely yet, but you can see we've had a steady increase in unique patients. Now, you'll notice that fiscal years 19 to 20 were excluded because at that time our data was corrupted by all things COVID-19. And we did not show prior year's data because our definition of primary care had changed. But the takeaway from this slide should be obvious, is that we continue to grow. And this is a good problem to have. Many practices and many health systems here in New York, as well as across the United States, have had just the opposite. They're losing patients. We, on the other hand, continue to grow. And as we do, you'll see on the bottom graph that our third next available, which is a marker of our access for patients, although had been at our goal of less than 14 days for the past few years, has recently ballooned up. And in fact, it is 22 days. And that is the problem that we're trying to solve. Now, when Hannah and her team did a deeper dive to understand, why did we see such an increase in our third next available, what they found is that we had over 20,000 patients waiting for an appointment. that we were unable to schedule. 20,000 patients. So that is a very large number. That's the problem we're trying to resolve. And so how are we going to do this? How are we going to create more access? Well, there are a couple of ways that we're going to do this. The first is through template redesign. And again, all of your ambulatory care team should be well acquainted with this process. We're going to be shifting the care for our chronically ill patients who are otherwise stable from seeing them 3 times a year just to then now seeing them 4 times a year. So 1 less visit per year. We're also going to change the percentage of appointments that are released at certain times to meet the known demand. This is what we call our rolling templates, so that you will always be able to create and have access on your templates. But the reason why we're here today is really to talk about this second piece, right? And that's our 20-minute new patient appointment slots. And the benefit of doing this is several-fold. Number one, it adds more new patient slots, right? That's a given. But equally important, by decreasing from 40 to 20 minutes, not only does it allow for more new patient slots, but it also allows for more revisit slots per patient per year. And we know that the number of new patient slots a provider has will be based on their empanelment, meaning how many folks, how many patients they're responsible for. And we're going to recalculate that number every 3 months. So as your panel grows, the number of new patient slots that are allotted to that one provider will change based on their panel. And I think the next slide really illustrates this very nicely. And again, huge shout out to Hannah and her team for kind of doing this higher math, if you will, right? And so although it is somewhat of a busy slide, what I want you to take away from this, on the left-hand side, you're going to see how full a provider's panel is. Anywhere from it's full, no room at the end, you're at 100% or greater, or you're not so full at the end, you're 50 to 59% full. And based on those calculations and those numbers, it will show the number of new patient slots that that provider will have scheduled during a month. The middle column then shows the number of PCPs across our system that are in those categories, just so you can get a sense. And you will notice, right, that the vast majority, 2/3 of our providers, not 2/3, excuse me, but 72, the largest number of our providers are already full. And only 34 of our providers system-wide are at 50 to 59%. And it shows you, sorry, to the last column, what that percentage is for the system. Now, these numbers, these estimates are based on a 1.0 FTE of direct patient care. It allows for 2.5 revisits per year for each patient in the panel. And again, by higher math, at this rate, a provider, one of those 11% of our PCPs who are at 50 to 59%, they would be 80% impaneled within 10 months. So within a year, they would move from 50% impanelment to 80%. Okay, so as we do this, most importantly, and I really want to emphasize this, most importantly, how do we support our providers? We all know change is hard. I am the first to admit change is hard, but we have a burning platform. We need to create access for patients who have no alternatives and have nowhere else to go to for healthcare. So we're going to do a couple things to support our providers, right? First and foremost, I just want to remind each and every one of us that all of our sites have CDTM pharmacists. Again, shout out to Dr. Jackson, who led this initiative and initiated it here at New York City Public Hospitals. These are providers who can help take care of our uncontrolled patients with diabetes and titrate their meds and get them controlled. They exist today. We're also going to lean on our collaborative care colleagues, right? These are our social workers and our psychiatrists that are embedded within primary care to help take care of patients with comorbid diagnoses of depression and or anxiety. We're going to continue to work with our chronic disease nurses on our treat to target nurses for those patients with diabetes and hypertension, respectively. And then very exciting, working with Sherilyn Ray from my office here at Central Office, we are supporting the sites to make sure that all of our nurses in ambulatory care are able to do non-patient specific orders, also known as standing orders, so that when they're seeing a patient for some education, they can say, oh, look, this is a patient of Dr. Wallach's, and I see that they're due for their Shingrix vaccine or their tetanus booster, and I'm going to go ahead and order that for that patient because they will be empowered to do so and have that ability. So that all exists today, but I wanted to call that out and make sure that we are taking full advantage of these team members. Remember, primary care, as I say all the time, and Hannah makes fun of me, but as I say all the time, primary care is a team sport, right? And we really look at the provider as being that quarterback, but we have an entire team, and it takes a team to be able to provide high-level care that you all do on a daily basis. But we realized that wasn't enough. And so in addition to those team members, we are going to add 2 additional folks to the roster. The first is something called a care team contact. And you may say, hey, Dr. Wallach, I've never heard of that before. And you are correct, because in fact, this is a brand new position. It's a new title. In fact, it is so new that we're continuing to work with our human resource colleagues to come up with the exact title for the corporate job description. And I'm happy to say we're almost there. So bear with us, but we're almost there. That said, I tend to think of the care team contact as a PCA plus. This is a person who is very familiar with the workings of the clinic and understands a little bit about the clinical milieu, understands kind of what it means, what happens in a primary care practice. And they will become that, what we're saying is the first touch for patients who have a clinical issue and need to get a hold of their care team. They can do a lot of that triage, if you will, to understand what is the issue that the patient needs, and they can get that patient to the right person, whether that's the provider, whether it's to the nurse, whether it's to somebody else on the team. But they're going to kind of help do that first touch. The second team member that we're adding is a physician assistant. And you'll see in a moment, I'm going to share our model, but the physician assistant that we're talking about here is in addition to what you may have at your site today with PAs. And we are going to assign these new physician assistants in a 1-to-4 capacity, meaning for every 4 FTE providers you have, you will be getting a full-time physician assistant. And what this individual will do is they are going to help follow up and place orders for healthcare maintenance, things such as colorectal cancer screening or mammography for breast cancer screening. And perhaps one of the most important things for providers, something that Hannah and I hear on each of our town halls that we go to, is they are going to help with prior authorizations for medications and procedures. And so this is something we're very and particularly excited about to support our providers in the practices. And again, it is baked into the new staffing model. And in fact, I heard from one of my team members just this week that in fact, the budget modifications have been approved by Central Office Finance. And what this means is that a memo will be going out very shortly, likely within this week, to your Queens Hospital leadership approving the budget modification to add these physician assistants so that you can begin recruiting and bringing these folks onto your team. And so what does our model look like? Let's see if I can advance to the next slide. All right, here we go. So this is on the adult side. This is the adult primary care staffing model. And what you'll see highlighted are the 2 new additional roles. That's that a physician assistant, which is in the ratio of 1 PA to 4 FTEs. The care team contact is 1 care team contact to every 8 providers. And again, this is above and beyond all the other existing team members that you see listed here. And again, this should not be a surprise to your site. This has been our longstanding model for care. Okay, so just taking a step back, and then I promise, I'm happy to take questions or answer any concerns that folks have. But I wanted to end with kind of the big picture. The takeaways is that our overarching goal is we have that burning platform to create more access for new patients so they can enter our system and get that high quality care that you have been providing day after day, year after year. The pathway to do so is we are going to decrease the time of our new patient appointments from the current 40 minutes to 20 minutes in length. But in doing so, we are going to add care team support members to kind of help take some of that work off the shoulders of the continuity PCPs. So what do we want you to do? We want to make sure that you're engaging members of the care team, that you're taking full advantage of the entire team, the pharmacists, the chronic disease nurses, the collaborative care folks. We want to remind providers that Rome was not built in a day and that not everything has to be done in the first visit. And I will tell you, for type A personalities like myself, that's hard, right? That's a sea change. I was always raised, do everything while the patient's in front of you. And I have to remind myself that we don't have to do every single thing in the first visit. Rather, we need to prioritize and triage with the patient collaboratively and decide what are the most important, the most salient things that we need to address today. And then we will see that patient back subsequently. That's the beauty of primary care, right? It's a longitudinal, it's a long-term relationship. So don't have to do everything in that first visit. Again, very important. I really want to credit Hannah again and her team on this. But the number of new patient appointment slots is not random. It is actually based on the provider's panel size. And again, we are going to look at panel sizes at a cadence of every 3 months and readjust the number of new patient appointment slots assigned to that provider based on their panel size. Because we know the more full you are on your panel size, the less room you are going to have for new patient appointments. And as we've always said, once our panels are full, and if there is still demand for our services, the only option for us at that point will be to grow. And that means adding new providers, adding new nurses, adding new CDTM pharmacists. We're not there yet today. We still have room on our panels. But once we get to that place, that will absolutely be our method for creating additional access. And then the last comment, and then I'll close out and ask Hannah if there's anything she wants to add, is just to say that for now, a reminder that both geriatrics and adolescent medicine will retain the ability to schedule their 40-minute annual wellness visits, right? So I think, again, hopefully you guys are aware that CMS allows for an annual wellness visit for these groups of patients that can be 40 minutes in length. They have some criteria that need to be accomplished during those visits, but they will continue. So let me pause there, and I'm going to stop sharing my screen. But Dr. Jackson, is there anything that you wanted to, kind of share or add to the presentation?
No, I think you got it all. I really want to make sure that we have time for questions or any feedback from you guys.
Great. All right. Well, that's all we've got. Happy to answer any questions or address any concerns from the Queen's Hospital folks.
Thank you very much, Dr. Wallach. Are there any questions from the auditorium? Dr. Lopez.
You would address how you would
Dr. Wallach, were you able to hear the question?
I was not, unfortunately. Do you mind repeating it?
One moment. We're going to get him mic'd.
Awesome.
While we're getting him mic'd, I saw one on the chat, if that's helpful.
Hello?
Someone asked if this applied to obstetric or gynecology patients. So this applies just to primary care. And by primary care, we mean adult medicine, pediatric medicine, and then virology is actually not part of this right now because they have a slightly different staffing model. And then geriatrics.
Thank you. Next question, Dr. Lopez.
Yeah, actually, I have two. The first is, what is the plan to address limited English proficiency patients in 20 minutes? It's a very large proportion of our population here. And the second is that time allocation, you lump in all of the physicians, PAs, and NPs as providers. Obviously, the physician would have to supervise some of the PAs and the providers. And how does that time allocation go? It's not the same thing.
Great. Yeah, no, thank you for those questions. I will start and then I'm happy to have, kind of have Hannah jump in. But just to say, indeed, Queens is not unique. I practice at Bellevue, as you've heard, and unfortunately, English is the only language that I'm proficient in on most days. I'm lucky at that. And so I use the interpreter phone or the iPads on a regular basis. And that is no different, quite honestly, whether it's a new patient or a revisit. It's a challenge that we have working at New York City Health and Hospitals. And quite honestly, it's one of the reasons why I'm here, because I think it makes for a richer experience with our patient population. So there's no difference between
If
the
I
two.
may, Dr. Wallach, I disagree. It is very different, and it takes a lot more time when you can find an interpreter that speaks the correct dialect.
Okay, so again, we can agree to disagree. As I said, we are very lucky at H&H that we do have over-the-phone interpreting. It is something that we have worked very closely with our DEI colleagues. And in fact, we monitor connect times for languages. And yes, there is no question that certain languages, and certainly those that are more rare, it takes longer. But overall, when we look at the connection times, on average, we do pretty darn well. And yes, again, there's no question it takes longer to do a visit for somebody whose language is discordant. Nobody's arguing with that. We completely agree with you. But it's no different than a revisit or a new patient visit. And in fact, some might argue that when you're using an interpreter, certainly an over-the-phone interpreter, you have the ability while the interpreter is speaking with the patient to do some of your documentation. And that's one of the things that I've used as a tip or a trick to make my visits more efficient. So anyway, just to share that out loud, but nobody is discounting the fact that language access is an issue, but it is no different from new patients or for follow-up visits. Hannah, I don't know if there's anything else you wanted to add, to that.
No, yeah. So I think I will just say, I want you to know that this comes up all the time. So everyone does feel this, and same as Dr. Wallach said, where I practice at GUV, I don't speak Mandarin, but 90% of my patients do. And so also I'm a large user of interpreter services. This is, as Dr. Wallach said, truly my revisits are no easier than new patient visits when it comes to language discordance. But I do think that our new provider I've found has really incredible connection times. And so if you're experiencing connection time issues, like, we want to hear about that immediately. This is a new vendor. And then in addition to that, exactly sort of what Dr. Wallach said, the trade-off is when I do have my occasional English speaking patient, I don't write any of my note during that visit. When I have my Mandarin speaking patient, I write almost my entire note during that visit. So trade-off as far as sort of where the time's coming from. But I do want to acknowledge that is a real thing, just not something where we felt like a new patient visit was any different than a revisit.
And just to add, based on the feedback that we have heard from these town halls, one of the initiatives that we are currently working on, which quite honestly has fallen by the wayside over the years, is we're going back to look at our provider profiles
Yeah.
to see what languages providers are proficient in, if they're in addition to English. And we're going to be creating a database with our contact center agents, so that, let's say, for example, in the scenario that Dr. Jackson just shared, that a patient who speaks Mandarin calls and wants a new patient appointment. That will now be added to the Epic profile for the provider. And moving forward, once this is built, hopefully in the coming month or so, the goal will be that agent, to the extent that they can, will schedule that new patient appointment with a Mandarin speaking provider, again, as available. So again, we have heard you loud and clear, and agree that hopefully that will give us some relief. Now, to your second question about the PAs, right, and the fact that they have to be supervised, indeed, that is correct. PAs right now require a sign-off on their notes, and that is not changing today. However, as you probably are aware, at the New York State level, there's a lot of excitement and a lot of talk. Dr. Hochul has come out in support of making physician assistants more akin to nurse practitioners, being independent practitioners. We're not there yet. Although looking into my crystal ball, I believe that is the direction that we are heading and that we will get to within the coming year. But again, remember, that does not have to be synchronous, right? A PA doesn't have to, in real time, come to the provider. Rather, it can just go to their in-basket and they can sign off on their note. And so again, we are aware of that. We agree, and we continue to advocate at the state level to make them more akin to nurse practitioners.
I did see one question about panel size that I want to make sure we do show you guys, and we'll make sure we send this out to Queens after. But someone commented that there's nowhere that it shows what your panel size is. So I do want to make sure that everyone knows about this great tool. So if you are in the population health dashboard, you can get there many ways. And like I said, we'll share some of those ways, including our AmCare SharePoint. If you click here, it will bring you to our empanelment dashboard, and you can drill down to the level of provider. So you can actually see your panel. So I will use myself as an example. I am an under empaneled provider. We'll look at Gouverneur, and then we go to provider panel sizes. And so this is a great tool, and we have another dashboard again that we can share with you guys in the meeting notes that actually shows you how many then new patients you would have based on your empanelment. So if we search for my name, Jackson, again, I'm ready to embarrass myself here. I work just one session a week, so I'm 11% continuity, and I'm 53.6% full, meaning I have 104 patients because I just moved clinics. So that's everyone can do this, and you can do this again at the level of your clinic or at the level of you specifically. So I just want to make sure that you do know that exists. And if you're having trouble finding it, please don't hesitate to reach out, because we love talking data.
Yeah, and look, we've sent out tip sheets. I hope folks get my weekly Upshot newsletter, which goes out to all of ambulatory care. We have used that as the source of truth to kind of share this information and that data, including tip sheets on how to access these dashboards, which are so critical. So if you're having issues, please let us know. We can speak with your leadership on the ambulatory side to make sure it's reaching all of your in baskets. The other thing looking and monitoring the chat here, just to say again, I want to reiterate that the 40-minute annual wellness visit for geriatric patients is alive and well. And somebody wrote in the chat that you're not allowed to do that. And I would just say that is incorrect. The 40-minute annual wellness visit for geriatrics, as well as for adolescents, remains live in our system. And happy again to chat offline with leadership if there's some confusion. Somebody also mentioned, of course, my favorite topic, and that is space. And that is near and dear to my heart, because again, where I work clinically at Bellevue, we struggle with space as well. And certainly if we talk about bringing in or bringing on additional team members, where are they going to sit, right? Where are they going to live? And so a couple of comments, and I'm not sure about the Queen's specifics, but one of the ways we started to address this at Bellevue is we've moved several of our clinics, we've expanded into evening hours, right? So now adult primary care has always been Monday through Thursday till 8 o'clock at night. We now have optometry Monday through Thursday until 7 o'clock at night. Cardiology is expanding 3 nights a week into the evenings as well. And so that is a way that you can better utilize rooms. The other piece to this, just to say out loud though, is that the PAs and the care team contacts that we are bringing on as part of this revised care team model don't all require rooms. Remember, these PAs that are being onboarded are not going to have their own panels. Their sole job is to support the providers that they're working with. A lot of the work that they're doing is going to be telephonic or virtual. And so they just need a touchdown space. It doesn't have to even be in the AmCare clinic proper. Again, we're happy to work with your ambulatory leadership on site, but again, they do not necessarily need exam rooms or even space. At Bellevue, we're creating hoteling space or touchdown space in a building adjacent to our ambulatory care building, because again, we understand that space is a real issue in our system. The other thing that I saw in the chat, and then I'm going to flip it over to Hannah as I can catch my breath, but the next item I saw was about PCA training. And I'm so glad somebody brought that up. And just to say out loud that if there's opportunity or need for improved or retraining of our PCAs to help with clinic efficiencies or whatever processes that you feel like would be helpful, please reach out to myself and my colleague Sherilyn Ray, who is my special advisor for ambulatory care nursing operations at the sites. She could work with your leadership at Queens, and we are happy to do additional training for the PCAs. We're happy to share best practices. One of the benefits of working in a system as large as ours is that we can see what has worked well at one site and then quote unquote steal that and share it at another site. And so we would be more than happy if that's a need that's been identified at Queens, we are more than happy to help with those trainings and bring some knowledge from some of the other sites. And then, of course, with the caveat that we want to steal from you and get your best practices and things that have worked well and share that with our colleagues. Hannah, do you want to, there was a question about CDTM pharmacists, and I'm going to punt that to you since you are the creator, if you will, of that amazing program. But it was something about CDTMs here in our adult primary care. You got it? All right.
Yeah. So I'm seeing CDTMs are not able to schedule only the uncontrolled diabetics earlier than 3 to 4 weeks. My guess is what you're saying is for patients who have uncontrolled diabetes, the wait time is still 3 to 4 weeks, and that's problematic at Queens. So Queens, I'll just want to give a shout out. Your CDTM pharmacists are really some of the best in our system and have really had incredible results. If it feels like we don't have enough pharmacists for your providers, that's something that we can absolutely solve. So Josh Rickard in our office oversees our CDTM pharmacy program. I'll admit occasionally there's like a vacancy, but they never last very long. And so if it feels like you're not having the access that you need, we can definitely address that. I will say being able to see a pharmacist within 3 weeks after seeing you does feel generally like a pretty good setup. But I appreciate that some people need to be seen sooner, and we can definitely work with you. So that is something. And Josh, who you may or may not know, also practices at Queens in your geriatric department. So he is very close to that work, and we can definitely work on that. But absolutely, I think you guys use them very well, and they do really good work. So we can follow up on that.
And I just want to shout out and say, let's take a step back in time before we had CDTM pharmacists. And I just want to say, wow, right? Like what a game changer it has been to add these team members. And I love your question, right? Because you're basically saying we have CDTM pharmacists, we know how amazing they are. We want even more access. And to me, that's a win. And so thank you for that comment. Because we understand how helpful they are to the care of our patients. And as Hannah said, we are happy to continue to work with you to improve those efficiencies and access, to them. The other thing that I'm seeing in the chat, moving on to the next question, is about open charts. And I really want to thank the individual, for raising this, because again, this is an issue that's not unique to Queens. It's not unique to New York City Health and Hospitals. It's not even unique to New York City. It is literally a nationwide problem. And as a practicing provider myself for over 25 years, quite honestly, it's been the bane of my existence, right? Charting and documentation. I think they alluded in their chat to what I call pajama time, right? Meaning when I go home at the end of the day, before I go to bed, signing off on my charts, completing my documentation. And nobody wants that, right? I'm not paying you. I'm sure Mr. Moore is not paying you to close charts at night, right? And we want you to be able to do your work during the business day when you are getting paid. And so again, by adding these additional staff members, the goal is to assist you, take things off of your plate, not have you do prior authorization so that you get time back into your schedule to finish your notes, to sign off on in-basket queries, and be able to get home and then be at home with your family and loved ones and not have to do work. Now, not that technology is the answer to everything, although Dr. Jackson teaches me every day that it is, because she knows that I'm a little bit of a technology Luddite. And those of you who know me know that to be true. But I will say, and I'm going to punt it over to Dr. Jackson again in a moment, but one of the things that I personally am very excited about, because we have heard this feedback over and over again, and we agree with it. But one of the things that we are looking into is something called ambient artificial intelligence, or ambient AI. And for those of you who are not familiar with this technology, basically what it is the computer is listening to your encounter with the patient. In many ways, I think about it as like my Alexa at home, who's constantly listening in the background. But in this case, they're listening to your encounter. And based on that encounter, the ambient AI will be able to create a note. It will be able to create an order set, because as I'm talking to my patient, Mrs. Smith, you're doing well today, your A1C is controlled, I'm going to order a repeat A1C, I'm going to order a basic metabolic. It will take that conversation and actually create orders in the system. The provider then just has to hit accept. And so this is not something that's a year off. This is not something that's 5 years off. This is happening today in some health systems. And again, I'm going to push this now to you, Hannah, because I know you're leading our AI efforts here in ambulatory care, and I'm very excited about this as a possibility, as a tool to help our providers.
Yeah. So, and I'll just put out there, if this is something that's interesting to you as we sort of continue to sort of grow our working group, we'd be happy to sort of get more folks engaged and sort of figuring out what solutions make the most sense. I think, you know, in speaking to people who work in systems who have this, for some people, this can be life-changing. For others, if you have already made Epic your best friend, it, you know, it only adds so much. But I do think across the board, it will really be a big deal when it comes to documentation. So I'm really looking forward to that. And we'll be starting sort of a formal RFP process shortly to understand sort of what different vendors are out there and make sure that we get the one that makes the most sense for us. Things that we are paying attention to, just in case you're wondering, because we did the same thing when we picked our video visit vendor, is they have to have all the languages in the world. So, you know, we are making sure that they're hearing the things that are most important to us in particular and what makes H&H special. And certainly language concordance is a huge piece of it. So I just want to put that out there as well.
Thank you, Dr. Jackson, and
Another
thank
question.
you, Dr. Wallach. Before you answer any other questions in the chat, we do have a fairly packed audience,
Oh,
and
great.
Sorry.
we have a question from the floor. I believe that's Dr. Lewinson. I'm not sure.
Can you hear me?
We can hear you.
Yes. My question, what for the panel?
Actually, we
Or an
can't
F-
hear you. Can you check the mic and have her speak up a bit?
Can you hear me?
Much better.
Okay. What is the panel size for an FD? And how many patients do you expect to see?
Great. Hannah, do you want to take that? It's just asking what our panel size is.
Yeah.
Yes.
So
Margaret.
for 1.0 FTE,
What a
the
full
panel-
panel is?
Yes. Yeah.
Yeah.
Yep.
For 1.0 FTE, the goal panel size or a full panel is 1750. That comes down if you are a supervised PA or NP. This has nothing to do with residents, so they're not part of that either. And your administrators have worked very closely with our office to make sure that we understand what your FTE count is, and then have calculated your panels based on that. That dashboard I showed you is accessible to everyone. You should check it out. You should look at it. You should play with it. It's got a lot of great information beyond just your specific panel size to talk sort of about what your patient breakdown is. So that is available.
And I just want to add to that if I can. Remember that the target panel size, as Dr. Jackson just said, is 1750 per 1.0 FTE. But remember that 1750 includes both active and
Yep.
inactive patients.
Yes.
And just as a reminder to definitions, keep me honest here, Hannah.
Yeah.
But an active patient is somebody who's been seen in the prior 18 months.
Yep.
And an inactive patient is somebody who's been seen in 18 months to 3 years ago.
Yes.
So that total number, inactive and active, adds up to 1750, which is our target. And when we look at it, again, keep me honest here, Hannah, I think when we talk about active patients alone, we're looking at around 1,300. Is that correct?
About 1,200 to 1,300 max, really. So we don't have any providers with more than that as far as patients who are actively engaging in care.
Yeah, it's a great question. And then also just to reiterate, what Dr. Jackson said, everything we're talking about today with the 20-minute new patient appointments is for attendings or advanced practice providers who are functioning as PCPs. House staff, our learners, are excluded from all of this, right? There's not the expectation that residents have 20-minute visits.
Thank you. Are there any other questions from the floor?
Yes, I have another question. Can you hear me?
Yes.
Yeah.
Hi, my name is Dr. Salih. Dr. Wallace, I see you talking with a lot of excitement about this new initiative for pharmacy and all this extra help that you had in your model. My first question is, where is this help? This program was implemented, I would say, more than a month ago. We don't have that extra help. You mentioned that you don't feel it's needed yet. Where do you base that? That's question number one. Question number two, have you received any feedbacks from providers? And let me tell you, there have been rallies here at Queens protesting against this change. There have been surveys done among doctors, and let me warn you, a lot of them said that they will be quitting because of burnout and because they feel they cannot provide the care that their patients deserve. And number three, I know we're trying to meet our ends. But at the end of the day, is demand and supply. So you have 20,000 appointments, you hire more doctors. That's common sense. Why you guys in your offices sit there coming up with some innovative models when it's that simple? You have more patients, that means you have business. Hire more doctors rather than giving some extra team, which can do just a fraction. A doctor can do a more comprehensive care. They can do education, they can sign the chart, they can build rapport. Thank you.
Yeah, no, thank you for your question. And I have to say, I'm really sorry because I hear in your voice your frustration, and forgive me if I hear anger, and that's upsetting for me to hear that because it pains me, because I don't want any of our providers to feel that. And so let me see if I can start. You had 3 questions. Let me see if I can start to address some of them and hope allay some of this concern of yours. So first and foremost, the CDTM pharmacists, the collaborative care team, the chronic disease nurses and treat to target folks, that's not new, right? All that staff is there. It's been part of our model for quite some time. It's working very successfully. I've heard this afternoon that even at Queens, the CDTM pharmacist is an overwhelming success. You need more and better access, and we'll work with you on that. So all of that exists today. To be very clear, the 2 new roles that we're adding are the PAs and the care team contacts. And as I said at the beginning of our chat this morning, the PAs have just been approved by Central Office Finance. Those memos will be going out to your leadership this week to be able to add them to your budget so that you can hire and bring them on board. In a perfect world, absolutely, 100%, we would have had these folks onboarded and ready to go at the beginning. Unfortunately, we don't live in a perfect world, and we had our burning platform of 20,000 plus New Yorkers who had access to zero care. And so we felt very strongly that it was important to start. Now, as part of this, again, understanding that you can't get water out of a rock, what we have said from the get-go is that all of our sites have the ability to control and use your staff how you want. And so, for example, using my clinical site at Bellevue, and again, I want to remind you, I just don't sit in an office at Central Office. I see patients as well. I'm in the trenches, and my practice is no different than anybody else's. But just to say, what we've done at Bellevue is we said, okay, look, this additional staff isn't here today. We know we need this staff. I agree. I admit that. So what we decided at Bellevue is that we took some of our existing PAs that were part of our practice, and we said, you know what? We're going to need to reassign some of their clinical work to support our providers as we move to 20-minute visits until the new PAs are onboarded. And what that means at Bellevue is that we have decreased some of our same-day access, where it may take an extra day to get back to a patient. We may get back within 72 hours instead of 48 hours. It's a trade-off in this transition period, and I'm not going to argue with you. I agree 110% that it is bumpy right now, but I assure you it will get better. The PAs have been signed off. We should be able to recruit for them and get them onboarded in the next couple of months. And the care team contacts is coming right around the corner. Now, with regard to your survey, and I'm familiar with the survey you're alluding to, and I look forward to working with doctors, councils, and others. We want to be collaborative. We are happy to see and sit down and review any survey. But again, it breaks my heart, quite honestly, when I hear that providers are going to leave. One of the things that I'm most proud of in my position here at New York City Health and Hospitals is our providers and our teams in ambulatory care in particular. Just last week, I sat with our folks from managed care, and I was shown the fact that at Health First and MetroPlus were amongst one of their most highly performing networks in their entire systems. And that gives me pride. And that's not because of me, that's not because of Hannah, it's because of you. It's because of each of our frontline providers doing what they do on a daily basis. And we don't want to disrupt that. But it really does. It breaks my heart to hear that folks are saying that they are going to leave our system. At the end of the day, I can't control what a person does. If that's the decision for them, then that's their decision. All I can do is say, give us a little bit of time. We are working. Hannah and I have been doing a number of town halls. I think we've done 6 to date to get this information. We've made changes based on that feedback, but we want to work collaboratively. This is not an us versus them. This is an us all together for doing what's best for our patients here at New York City Health and Hospitals. And then lastly, to your third question, again, just to reiterate, as I said before, once our panels are full, that is absolutely our intention to add more providers. But if you look at our panel sizes today, and again, all of this is transparent data. Hannah showed you, we're happy to resend out the tip sheets. All of this information is readily available online. But currently today, our panels are not full. And we have room to grow with our panels. And so we cannot add new providers, new primary care providers, excuse me, until we've done our responsible thing, and that's fill our current panels. And so I just want to be very clear that that is absolutely on the table. Once we fill our panels, we understand, we agree with you. That's how we continue to grow. We're not there yet.
Thank you very much, Dr. Wallach. Anybody else from the floor? I was about to do that, but come on up, sir.
Maybe I can do it from here. Dr. Wallach, Dr. Jackson, thank you very much for accepting my request on short notice to spend some time here with us to address one of the burning issues here. The reason why I requested you to address this, there was one individual who had written about the 20-minute visit and had put it in the context of cutting services. And my forum as a town hall is to provide information, to clarify information, and to provide any kind of misinformation that we might have. So once again, thank you very much for spending this time with us. And if there are any more questions from the audience here, I'll make certain that we channel that to you to get responses. Thank you very much.
Perfect. And if I could just say, Mr. Moore, thank you for inviting us to the forum today, and to the members in the audience and those online. You all are very lucky to be working at Queens Hospital under Neil Moore's leadership, and in addition to the ambulatory care team. I have to say, all teams are not created equally amongst our system. And certainly from my perch, along with Dr. Jackson, who I'm sure will agree, it has been an absolute pleasure to engage and work with the ambulatory team in particular at Queens, who have been really wonderful. And I would just offer Mr. Moore's invitation that if you have ongoing questions, my email, Dr. Jackson's email, we're readily in the system. Reach out to us directly. As I said, we want this to work. This is about our patients, but at the same time, we recognize that we need to make sure our staff are engaged and happy at work because they're doing amazing things, and we want that to continue. As I said, it breaks my heart when I hear that people want to leave or they're unhappy, and so we want to work together. So thanks for having us this afternoon.
Thank you, Dr. Wallach. Thank you, Dr. Jackson. We have 10 minutes left. Are there any questions not related to the topic we just covered for Town Hall? Mr. Moore, is there anything special that you would like to
Yeah, so
to speak on?
today was supposed to be a day that I do a full-blown presentation to you, and just let me put out a teaser. The presentation was really going to, I've been here for 3 years and 9 months already. And I created a strategic vision. Many of you have seen that strategic vision. I wanted to share with you the strategic, refresh your minds for those who have not seen it, show it to them, and who have seen it, refresh the minds of those individuals. And then I wanted to talk to you about what we were able, I'll say that, were able, meaning all of us were able to accomplish over the last 3 years or so. Queens has always stand above many others, but I can tell you it's phenomenal on the things that we have been able to accomplish, whether it is on our quality side, whether it's on patient safety, whether you all know about the last Joint Commission, whether it has to do with the numerous accolades that our nursing department has received. And so what I want to do is walk you through all those visionary goals and then bring you up to date as to what we were able to do, and then talk about what the future would look like. So count on me for coming back to you next month to talk to you about that. I think it's important that we do a time check on as we close out this calendar year and as we step into a new year. So where we are and where we need to retool. We've done several initiatives. I want to share those initiatives with you all. Many of you have been involved in those initiatives as well. So Ms. Dasher, that's all. And maybe we can take some general questions if they have, and then we can close it out until next meeting.
Vinny, are there any questions? No. Did you want to take any questions related to the conversation that we just had? Could you read the first question then? Oh, there were no questions.
You hear me now? All right. I'm sure y'all are aware. Change is hard, and I hear the pain. Most of us as physicians, and I'll speak for myself, we tend to be a little OCD, and we want things particular ways. But the model and the way we deliver care is evolving. And it's been a tough move to get from the individual doctor-patient relationship that many of us have known for years to a team concept. And so that's where I would like us to start thinking. What I feel might be happening is we're saying this is the expectation, and we're trying to fit it in how the way we have always been doing business. And what we need to do is probably sit in smaller groups, because each clinic and group of providers might be different, to say, how do we operationalize it and utilize the additional resources? All right, whether it's the PA that's working with 4 providers, what will that person help you to establish? All right. Translation, you heard some of the key things they did differently. Do your documentation while you have the translator on the phone. And if I have to do consent for something when I'm working clinically, I just take care of that consent same time if I know I'm going to be doing a procedure, and use that to give the patient the expectation of what the rest of the visit is. So we're going to have to work differently. And so I will gladly partner with each of you as to how, with the resources, we are going to execute things in a different manner. It is painful. The only person I've heard, and I think is Mark Twain, that likes change, they say is a baby in a wet diaper. All right, the rest of us, it's a struggle. And so this is so we're glad for the engagement. I'm glad for the passion I heard in the room today, but we're gonna get it right. We have hiccups. We work in a system that's not always perfect, and things get started and the resources you promise aren't there. But I usually tell folks, eventually we get it right. All right, and so we really want to partner with us, because the why is really about access of care. That's really what the why is. And so that's who we are as a safety net hospital. We want to make sure our patients have access to us. And we will do the balancing and the wellness. And we're working on the doctor's lounge and other things to say that we are hearing what you guys are saying. But we will continue to work through it. Thank you.
Thank you, Dr. Holson. Mr. Moore, I understand we have one question.
Yes, from the chat was related to the cafeteria or the new food service at the hospital. When will that be available?
I'll be happy to take that, but I'll leave that to Mr. Moore and Mr. Gelderd.
He's here, but we are going to get started.
He's here.
Yeah, I'll let you. It's happening, it's coming.
Yeah, so they started work already on Fresh on the Go Cafe. There's a new floor. They're working on the inside, building an office. It should be outfitted and ready to go by the end of January.
And
Let's get there first.
any other questions? Okay, so we want to thank all our presenters, and specifically we want to thank you. You would not, and we would not be able to run this if you were not present and engaged. So thank you so much for your time. Please notify colleagues who were unable to attend that they can view the presentations online by going to the webmaster email and clicking on the link. The time is now 12:58. We're yielding back 2 minutes.
Ms. Dasher, I'll take the minute just to acknowledge our new employees that I should have acknowledged at the top and welcoming them to Queens Hospital and for taking a chance with us as we have taken with them on the journey in becoming the best community hospital in the nation. I think is Dr. Lopez still here? Okay,
Yes.
you corrected me on that. Best community hospital in the nation. What did you say? Okay, all right, okay. Yes, so thank you all.
So I want to join Mr. Moore in welcoming our 30 new hires. That is quite a number for the last month. So we're going to close out now. Until next time, look after yourselves and each other. Thank you.
And thank you too.